Lou is recovering from COVID. I am just recovered from COVID. What you've heard is really, I think, amazing. And what we can say as we get started, that is that we're in a new era of treating obesity. Dr. Aroney has said it, the other speakers have implied it, and I think it is one of the most important conclusions of what we've seen today. I'm trying to figure out how to make this thing go forward. How do I make this go forward?
You can use it. Arrow.
Oh, this the arrow?
Yeah.
My disclosures for this presentation are, one, that I have the opportunity and pleasure to work in this area with a number of companies and a number of government agencies. But I should also disclose that as the independent discussant, I had nothing to do with this trial, and I was not involved in any way in its execution or design. So let's get started. There are now 3 strikingly effective and adequately safe therapies for obesity. The first is bariatric surgery, which we've known about for a long time. I'll go through that in a minute. The second is semaglutide, which you've just heard Dr. Aroney talk about. And now the third is tirzepatide. And I want to talk about what each of these 3 therapies has taught us about the efficacy or the effective treatment of obesity and what it can imply for the future of obesity care. Now, if you go back to the 1950s, we can see that bariatric surgery, which was introduced in 1954, and intensive lifestyle therapy, which has been introduced in a number of different ways over the last 60 or 70 years, have had fairly stable efficacy rates. Well, you can see that bariatric surgery has always given about 30% initial weight loss. The reason that this line on the top is of different colors is the major improvements in bariatric surgery over the last 60 years have been with regard to safety. In the 1950s, up to 10% of people died after bariatric surgery. Today, it's 0.1%, or a 100-fold decrease in the rate of mortality. And that's because of the introduction of laparoscopic bariatric surgery and standards and accreditation, which have made it, as I say, 100 times safer. Intensive lifestyle therapy at the other end of efficacy has been stable at around 4%, 5% durable weight loss over years. But it's improved also over the last 60 years because it has become more efficient and more standardized in terms of our ability to deliver it. The problem has been that medical therapy, which is the mainstay of treatment of most diseases that we address in all of our practices, has not been terribly effective. If you look over the first 40 years of the last 60 years, you can see that it's not been significantly more effective than intensive lifestyle therapy. There was a blip with fen-phen. Of course, it was taken off the market 2 years later. I identify here on this slide leptin, the discovery of leptin, because I'm going to come back to the discovery of leptin as a key landmark in the history of effective therapy for obesity. Not because leptin's effective, but because it gave us new insights. More recently, in what I'm calling generation 2 of anti-obesity therapies, what you see here is the introduction of some combination therapies that Dr. Aroney talked about, and liraglutide, the first GLP-1 receptor agonist that was approved specifically for the treatment of obesity. And you see that finally we're getting efficacies that are a little bit above, about double, what you'd expect to see long-term with lifestyle-based therapies. And then over the last 2 years, what we now see is the introduction of new therapies. First, semaglutide 2.4 milligrams, approved in June of 2021 for the treatment of obesity specifically. And then, of course, what we've talked about today, which is tirzepatide 5, 10, and 15 milligrams, although the efficacy data shown on this slide are 10 and 15 milligrams, as you've already seen. And this, as Dr. Aroney has said, is the introduction of a new era of this generation 3 of medications, and a new era that will lead to the potential for other medications shown here in gray. And they're shown in gray because we only have early data, either no clinical data or early clinical data on some of these agents. But what you see here in this generation 3 is the opportunity to not near, but actually equal or exceed the efficacy of bariatric surgery. So let's come back to that. So what has bariatric surgery taught us over the last 60 years? Well, it's taught us that magnitude matters, that weight loss magnitude matters. The reason that there are so many studies, including randomized controlled trials, that demonstrate that surgery improves comorbidities to the degree that it does, diabetes, sleep apnea, renal disease, fatty liver disease, is because the magnitude of the weight loss is sufficient to have a big impact. We have had in the medical side the need to demonstrate the benefits of small amounts of weight loss, but the real benefits have turned out to come from larger amounts of weight loss and even normalization or near normalization of body fat mass and body weight. And so if you look at, and this is a different version of the slide that Dr. Aroni showed, is it doesn't take a lot of weight loss to make improvements, particularly transient improvements, in a number of comorbidities. But in every case, as you see in the column on the right, in every case where it's been looked at, the benefits increase significantly with increasing weight loss. And that was demonstrated first in the bariatric surgical field. The second thing that bariatric surgery has taught us is that physiology matters. Bariatric surgery was introduced with the idea that you would restrict or the amount of food that somebody could eat, or you would cause malabsorption of the ingested calories. And because it worked, that seemed like a good logical, rational explanation. But what we learned from the earliest days was that if you simply cause malabsorption, as is shown here with extensive bowel resection, in this case for Crohn's disease, what you see is that people get hungrier. They compensate for the loss of the absorption by getting hungrier and eating more food, eating more calories. And that is now called the physiology of the weight-reduced state. In contrast, from the earliest days in the 1950s, when you have an intestinal bypass, which does cause malabsorption, no debate about that, what you see is that despite the fact that it causes malabsorption, it is an appetite suppressant. The operation is an appetite suppressant. So what it does is you see a dramatic decrease in appetite after the operation despite the malabsorption, which ultimately starts to come back toward normal, as you see here on the right side of this slide. Because as the body settles down to a new stable plateau, to a new defended fat mass, of course it no longer wants to lose weight, it wants to maintain the weight, and so appetite goes back up again. Now, I want to call attention to the fact that this paper was published in 1976. So it's taken us a while to even recognize what surgery has taught us. Whoops. Now I want to talk about, that was the lessons of surgery. What about the lessons of the second of the three therapies that I mentioned at the beginning, semaglutide? What semaglutide has shown is that GLP-1 agonism may not be necessary to prevent obesity. If you knock out the GLP-1 receptor, you don't get obesity. It's not like knocking out leptin or knocking out leptin receptor or even knocking out MC4. But GLP-1, despite not being necessary, is sufficient to overcome the pathophysiological lesions of most types of obesity, as you saw today and as you've seen in the studies of semaglutide. And despite the complexity of body fat regulation, there's at least one mechanism, GLP-1 signaling, that can substantially re-regulate the whole system. Even though it's not critical, it's not necessary, it can re-regulate the whole system. Now that's different from leptin. Leptin, as I mentioned, was discovered in it was described in 1994. But leptin is involved in the feedback regulation of fat mass, so that the brain that regulates this whole system knows how much fat the body has. And if you don't have leptin, you break the circuit. So the brain doesn't know how much fat it has, and so it keeps trying to deposit more fat and eat more food. And it's a little bit like a series electrical circuit. Because in a series electrical circuit, if you break any part of the circuit, the whole system stops operating. And so what leptin taught us is leptin is essential for the system to operate. But the lack of efficacy of leptin as a treatment for obesity teaches us that even though leptin is critical and necessary, it is not sufficient to re-regulate a system that is physiologically damaged, as is the case in most obesity. In fact, fat mass is regulated by a complex regulatory network that looks nothing like an electrical circuit. And that complex regulatory network is so detailed and so complex that it raises the question, could there be anything in such a network that could re-regulate the whole thing? And so the importance of recognizing that GLP-1 receptor agonism is sufficient to re-regulate this whole network in a way that causes profound weight loss is really that lesson of semaglutide. Now, what are the lessons that we've learned about already from tirzepatide that we heard about this morning? Well, first, and very importantly, semaglutide's not a fluke. That another GLP-1 receptor agonist is equal or better than semaglutide in terms of achieving the same ends. But what we don't know about tirzepatide is really how it works. Dr. Aroni mentioned that it works because it has two mechanisms of action. I'm going to question that. Because it does have two mechanisms of action, but are they both necessary for the superior behavior of this drug? We don't know. And that becomes very important because if indeed there's a second mechanism, GIP receptor agonism, that is significantly contributing to the efficacy of tirzepatide, then we have a second way of re-regulating the system. We have GLP-1 and we have GIP. But if tirzepatide is merely a better GLP-1 agonist that also happens by chance to have some GIP agonism, then we haven't learned anything about a second mechanism. Because it's important for us to know, is GIP signaling a unicorn? Is it the only thing in biology that's going to be able to re-regulate this system? Because if it is, then we're not going to find a whole bunch of other things to complement it the way Dr. Aroni was hoping that we would. But if it's not, it becomes very important because if there are other mechanisms, then we truly have the ability, as with hypertension, as with diabetes, as with other chronic diseases, to be able to hit it from multiple different mechanisms. So learning how tirzepatide really works is going to be critical in answering this question. And identifying other mechanisms, none of which have been identified definitively, that are sufficient to normalize body fat regulation is going to determine the future opportunities in this field. Well, we know, you've heard it in different ways in the previous talks, that the treatment gap that we talked about before, that we have non-invasive therapies that don't work that well, and we have invasive therapies, bariatric surgery, that work very well along this line of identity between effectiveness and invasiveness. Well, that treatment gap was initially proposed to be solved by the introduction of endoscopic approaches that mimic bariatric surgery. As a gastroenterologist myself, I was very partisan toward that idea. But what we've learned is that those endoscopic therapies have not been that effective. And rather, what we've learned today and what we've learned last year is that the treatment gap has already been closed by these more effective nutrient-stimulated hormones therapies that we talked about. But what's even more important than this line of identity, where more invasiveness leads to more effectiveness, is can we do better than this in the future? Where with newer medications and combinations of medications, we actually move off the line of identity so we get more effectiveness without more invasiveness, as shown here in the yellow circles. And that really will depend on finding the new mechanisms that I propose we need to find to really get to the kind of future therapies that are going to bring obesity completely under control. Finally, I want to talk about the fact that as good as tirzepatide is, it's not perfect. There is no perfect therapy for obesity. If you look at low carbohydrate diets, they work. Some people to the left of the black bar here gain weight, but most people lose weight. But look at the breadth of the variability, the breadth of the response. If you look at drugs, this case it's liraglutide I'm showing here, you see the same thing, the same breadth of response. If you look at a device, the duodenal liner device or the endobarrier, the same thing, the curve is shifted to the right. And if you look at bariatric surgery itself, gastric bypass in this case, you see that the breadth of the curve is the same, even though the average is much greater. The average weight loss is much greater. Well, not surprisingly then, we've just analyzed the data for tirzepatide, as you can see here, and you see that the curve looks just the same, except that it's shifted to the right. It's not any narrower. The standard deviation is about 10 to 12% in all of these different curves that I've shown you. But because it's shifted to the right, you already know that 2/3 of the patients lost more than 20% of their body weight in the SURMOUNT-1 study. I've taken it, because I have these data, I've taken it one step further. 23%, nearly a quarter, lost as much weight as you would see with bariatric surgery, 30%. With the good bariatric surgery, not with banding, but with bypass and sleeve gastrectomy. At the other extreme, only about 3.7% lost less than 5% of their body weight. But you can anticipate, just based on the data from the SURPASS trials, that people with diabetes there are going to be more people who lose a more modest amount of weight. So this variability becomes important. We will not solve everybody's obesity problem by treating them all with tirzepatide, even if we could. So we have to remind ourselves as we move into this generation 3 of anti-obesity medications, this new era of therapy that is made possible by semaglutide and tirzepatide, although tirzepatide, as noted, has not been approved for the treatment of obesity, at least not yet. These new therapies give us tremendous new opportunities, but with those new opportunities come an enormous amount of responsibility. For providers, we have to learn how to use them. We have to learn when to use them, and we have to learn how to use them safely and efficiently, not only effectively, but efficiently, because we can't we can't just willy-nilly give everybody these drugs. For public health officials, we have to respect the fact that we're in a new era, and we have to change our attitudes about obesity. For employers, the same thing. If you care about the productivity of your workforce, if you care about the health of your workforce, if you care about the bottom line, you may have to rethink coverage issues. For pharmaceutical companies, you can't be complacent if anybody from a pharmaceutical company is here, because we haven't come, as Lou said, we are at the beginning, not at the end of this pathway. The public needs to learn a heck of a lot more about obesity and about why it happens, and patients themselves need to learn a lot more. And everybody on this list needs to take a deep breath and diminish their bias, diminish the stigma that comes from that bias, and diminish their discrimination against obesity. Obesity is not going away on its own. We need to manage it. We need to understand the tools we now have, and we have to use them effectively and use them well. We need to continue to develop new tools and find out whether those new targets that I talked about earlier that can complement GLP-1 receptor agonism really exist or they don't. That's a biological question. We don't know the answer. And finally, we're not going to be able to treat everybody tomorrow. Amazon didn't start spending $1 trillion building distribution plants on the first day of business. They made money, and then they built a bigger business. And they made more money, and they built a bigger business. So we're going to have to prioritize in medicine how we're going to use these new tools. Are we going to prioritize the degree of obesity? That's the current criterion. The clinical severity, well, then we're going to, not just the amount of fat, we're going to need to have a severity score, which we don't have, that's more accurate. Or we could start by the overall cost of care and use the money that we save in care for those patients to invest in patients who perhaps don't cost as much. Or obesity that interferes with other care, such as orthopedic injuries, or organ transplantation, or cancer radiotherapy. Or patients in whom we've already invested, like people who've not done as well as we want after bariatric surgery. Or patients who are shown to be highly or predicted to be highly responsive. Maybe those should be first. Or specific subtypes of obesity. But whatever criteria we use, we have to work with all the partners that I talked about, all of the stakeholders, so that we come up with a strategy so that we don't expect society to go from 0 treatment of obesity to 100% treatment of obesity without regard for cost, benefits, risk, etc. But whatever we do, we need to take obesity seriously. We need to remind ourselves to take obesity seriously. And we shouldn't let these powerful tools go to waste. I have one more thing to say, which is during the course of this symposium, the New England Journal of Medicine, excuse me, published the paper, so it's online as of right now, that describes this symposium. Thank you very much.
So as we move into the Q&A, I'll invite the panelists to come up on stage. We've got to rearrange a few chairs. I'd like people to queue for questions. And I also want to announce that there will be a press conference at 11 a.m. With Dr. Bob Eckel and Dr. Yashrabov at 11 a.m. today. So, Dr. Ryan.
Yeah, Jamie, thank you so much. So I'm going to ask our panelists to come up here. We have 3 microphones to be shared, and I'll start with this question right here.
Hello, my name is Thomas Dahner from Hanover, Germany. I didn't hear anything about the potential chances of treating adolescents with something like that. We have the big problem that many of the type 2 diabetes medicines don't work well in adolescents. Any speculation how you would expect tirzepatide in this population?
Our mid-peds expert, Anya.
So there are trials for Surpass Peds. So it'll specific. Is it not on, Tim? Is the thing on? Okay, it is on. Okay. So Surpass Peds is specifically a trial looking at tirzepatide for adolescents with type 2 diabetes. So we'll have to see the results of that. But great question. Thank you. Absolutely. We need to be treating early.
Here. Yes.
My name is Elisabeth Mathisen from Copenhagen. My question to you is that there was a few ladies who became pregnant in the study receiving the study drug. Did you see any bad events in that? And my second question is, do you follow the women after the continuation of the study to see if they have a better chance of becoming pregnant?
So, so the first question was the people who got pregnant during the trial, is that right?
Yeah.
So for the trial, there was a need, a requirement to use highly effective birth control throughout the trial. So I don't have any data about pregnancies that happened during the trial, and we don't have any data yet about what's going to happen afterwards, after the weight loss and increased fertility. So we don't have the data, and we might have it in the future, but we don't have it right now. Thank you.
Okay, I'm going to go to the speaker in the back, and then to you, Dr. Garvey.
Sherry Horvath from Indiana. Since obesity is a chronic condition, as Dr. Oni had mentioned, we need to continue with treatment. Has there been any study put in place to see what a maintenance dose would be in the event that someone does reach their target? Do they maintain that highest dose? Do they back down? And is there a way we can argue this with the insurance companies?
Okay, I'll get started and then I'll hand the mic to Dr. Kaplan when he's feeling better. So specifically for tirzepatide, no. There are trials with semaglutide that looked at discontinuation of drug, and as we see, the weight gain occurs. And that is not surprising, because what these anti-obesity medications do is they decrease the body fat mass set point, the brain-regulated body fat mass set point. And so when the drug is taken away, the set point goes back up. This is exactly what happens if you have a patient with hypertension. If you start an antihypertensive medication, their blood pressure improves. What happens when you stop that medicine? The blood pressure goes back up. So the same thing happens with these anti-obesity medications. In terms of the question for the treatment dose or the maintenance dose, the treatment dose or the maintenance dose, there aren't trials of that yet, but that's a fabulous, fabulous question, and potentially we don't know what dose will need to be used. Right now we know we have to continue the medicines.
Sean Wharton.
So I can take part of that. So I was part of the step one. We had a extension of the study. So we looked at it a year after, where we just stopped the medication. We didn't follow them up. We didn't, in terms of, we followed them up in terms of asking what their actual weight was, but we didn't give them any advice, any phone calls, any dietary advice. We just let them regain the actual weight. They all regained weight. Those who lost the most amount of weight regained the most amount fastest. After a period of time, they got frustrated at having weight regain and started to use rescue therapy and started to plateau a bit. But the bottom line is the counter-regulatory effects and the science that Dr. Kaplan was actually talking about is very clear, that the weight regain will happen unless there is another alternative effective therapy. So we know that there's going to need to be maintenance. What that maintenance is and what that maintenance dose is going to be a question. And some people talk about CBT therapy, cognitive behavioral therapy, looking at a part of that to try to do maintenance, and other types of treatment options. But certainly the medication is, has been shown to, many of them, semaglutide, over a 2-year period to keep it relatively stable.
Tim?
Yeah, Tim Garvey from UAB. I'd like to congratulate Eli Lilly for bringing this molecule to us and all of the speakers for such great presentation. As impressive as the data was, as I was sitting here, I think some unsung heroes are also the protein chemist, structural biologist, and basic biologist that drove the development. But my question is, so the commentators, Lee and Lou, decried the fact that we have so many patients with this disease that go untreated. In fact, 2/3 of America. And we also, wasn't mentioned, but the social determinants of health have a big impact on this disease as well. Lower socioeconomic groups have higher prevalence. And if these medicines are going to cost $1,000 a month, how do we reconcile the need to treat larger numbers of patients with costs that can make this so prohibitive and inaccessible to patients?
Who's taking that one? Thank you.
If I can talk. It's a critical question, and although time didn't allow me to address it in my talk, equitable access to these new therapies is absolutely essential, and that's what I think Tim was getting at. Some of it's going to come over time because these drugs go off patent, and when they go off patent, they get less expensive. But that doesn't seem like a good public health solution to the problem that he's raising. We need to find ways of stratifying. And my second to last slide, where I talked about different ways of stratifying patients, are ways that are based on biology and based on clinical need. And if we start with biology and clinical need, then we can figure out how to put into place the infrastructure that will allow equitable access based on need. But if we don't come up with an approach toward biological and clinical need, we will never have a rational basis for pushing forward in the manner that Dr. Garvey was asking about.
Thank you, Lee. I don't think we're going to solve the problem of drug pricing in America this morning, so I'm going to move on to you.
Thank you. Derek Bone, Berkeley, California. Wondering if you could comment on or speculate on why you don't necessarily see a big increase between the 10 milligram and 15 milligram doses in weight loss.
Juan, you should do that. 10 and 15? There's such little discrimination between the 10 and 15 milligram dose in weight loss efficacy.
And that's a great question, and all of us asked ourselves that when we looked at the data and whether there was saturation of the mechanism. But the important thing to note is that different patients will respond differently to this medicine as they do to any other. And so some patients may have additional benefit from a higher dose, whereas others will need only the 5 milligram dose. As you saw, that was also impressive data. So I think we have to take that into context. Additionally, there will be sub-analyses done specifically to look at, is there an effect of gender? Is there an effect of age? Is there an effect of prediabetes? what are these other impacts, what are these other factors that can actually impact this? So those sub-analyses will be done, and we will have more information to know potentially which patients respond to which doses of medication.
Okay, we have 3 minutes left, so I'm going to start in the back and go forward, and we're going to try to do as many as we can. The last person in this row?
Christian Colon, Colombia. What's the evidence of tirzepatide in end-stage chronic kidney disease or liver cirrhosis?
Juan?
Yeah, it has not been studied in those in long-term clinical trials, but there have been, and I mentioned pharmacokinetic studies assessing tirzepatide, basically concentrations after administration in patients with varying degrees of renal disease, including end-stage renal disease, as well as hepatic function. So if you look at the tirzepatide, and this is for type 2 diabetes label, for example, there's no restriction with respect to renal function or hepatic function. But still, as with any medication, we need to take more care in those patients.
The middle microphone?
Ron Vicinore, New York. It was pointed out that GIP increases glucagon, and of course GLP-1 does the opposite. Have you measured glucagon levels to see whether there was appreciable GIP tone over the course of the trial?
Yeah, I'm not sure about, I'm sure they were measured in SURMOUNT-1. I don't know that for a fact, but certainly in the diabetes trials in the phase 2 study compared to dulaglutide in the SURPASS-2 study as well, there were actual reductions in glucagon with tirzepatide compared to the selective GLP-1 receptor agonist dulaglutide and semaglutide at the 1 milligram dose.
Thanks. Front microphone?
Yeah, Rosenstock, Dallas. I just echo what Tim said, but I will define this presentation as a total wow. It's just incredible. But despite the fact that doesn't seem to be that much of a dose response between the 10 and 15, I will bite the bullet and I will explore the 20 and 25 dosages. Has that been considered? And so you can get up there to the bariatric surgery.
Anybody know the answer to that one?
I don't know, but we can find out the answer from the team sitting in the couple front rows, and I'm sure they'd be able to answer you.
It seems to be the trend these days, Julio. So.
Shower?
Yeah, Phil Shower, Pennington Biomedical, and I'm a bariatric surgeon. And I must say, maybe one of the few ones in the audience, I am extremely excited and pleased to see these agents, tirzepatide and of course semaglutide as well, become potentially very effective and powerful tools that will complement bariatric surgery and maybe in some cases even replace it. My question is perhaps comments about using tirzepatide as an agent to reduce operative risk in patients who have very high BMIs who are preparing for surgery and or as adjunctive therapy for bariatric surgery.
Great idea.
Does Corral want to take it? Corral, do you want
Corral,
to take it?
please.
Corral, do you want to take it?
I completely agree with you, Phil. And, you know, actually, I think, you know, imagine the day when we can take a patient with a body mass index of 70 and turn them into somebody with a body mass index of 30, you know, with the functional gains when we combine medication and surgery exactly as we would do in cancer. So, you know, I would just say that this is not surgery against medicine. You know, I think it's going to be surgery with medicine. And that's how we're going to get most benefit for our patients.
So we're going to finish on time and under budget, and I'm sorry to the people standing at the microphones. Please come up and ask your questions individually. Thank you.